Inflammation will be the focus of this particular set of PowerPoints. We are moving into the lower GI tract, and specifically in this section we will talk about appendicitis and then the inflammatory bowel diseases of ulcerative colitis and Crohn's disease. The goals are listed here. The exemplars to be covered are appendicitis, and as I said, an IBD. By the end of this module, the student will be able to understand the inflammatory processes for each of the exemplars, understand the risk factors for the development of each exemplar, perform a thorough assessment of a patient with each exemplar, be able to apply nursing knowledge for the nursing care of each exemplar, and to teach the patient with each concern how to practice prevention behaviors to prevent the problem from occurring, how to identify the problem as soon as possible in order to minimize damage, and to understand and cooperate with treatment plans. So starting with appendicitis, what is it? Appendicitis is an acute inflammation of the appendix. It occurs most often in young adults, and it is the most common cause of right lower quadrant abdominal pain. It occurs when the lumen or opening of the appendix is obstructed. The initial obstruction is usually a result of fecaliths, which are stones of fecal matter, hard fecal matter, which is composed of calcium phosphate-rich mucus and inorganic salts. So when you realize that it's fecal matter that causes it, what are the implications for the patient should this appendix rupture? Imagine all that fecal material in through the abdomen. You can see where the concern, the huge, severe concern is. When the lumen is blocked, the mucosa secretes a fluid which increases the internal pressure and restricts the blood flow, and that's what causes pain. So think about that. You've got a organ that is size specific. It can't just grow big like a uterus. See how everything goes back to OB. But when the lumen of that is blocked and stuff cannot get out of it, the mucus cannot come out of it, that pressure will increase and it restricts that blood flow, and eventually it'll burst. The main complication of appendicitis would be if it does burst, they end up with peritonitis. Peritonitis is a result of a rapid process of acute inflammation, and all complications of peritonitis are extremely serious. Gangrene and sepsis can occur within 24 to 36 hours. It is life-threatening. It is the most common indication for emergency surgery. Perforation may develop within 24 hours, and the risk rises rapidly after 48 hours. So early identification, of course prevention is the best, but early identification and surgical treatment is required to save their life, quite frankly. What do we as nurses need to assess when we have a patient who comes in with abdominal pain? It is really, really important to track the sequence of the symptoms. Gastroenteritis and appendicitis can appear to be on the surface very, very similar, and that's why it's important that we get more depth with our assessment, specifically regarding the sequence of nausea, vomiting, and pain. If nausea and vomiting has happened before the pain, the patient has gastroenteritis. If the nausea and vomiting has happened after getting the pain, abdominal pain, those patients will have appendicitis. So understand that the timing of the nausea and vomiting in relation to the pain is vital to knowing what they have. With appendicitis, they're going to hurt first. With gastro, they're going to puke first. Okay, think of it that way. These patients often have a cramp-like pain in the epigastric or periumbilical area, and this progresses to pain in the right lower quadrant area, which is known as the McBurney's point. Discovered and diagnosed by, I'm sure, someone named Mr. McBurney. Pain that increases with a cough or movement and is relieved by bending the right hip or the knees suggests perforation and peritonitis. We're getting sick. Also with appendicitis, rebound tenderness occurs, and that's where the provider would palpate into the abdomen, which actually doesn't cause pain as much as when they let go of the abdomen. That will cause more pain. Both will hurt, but rebound tenderness will hurt worse. What labs do we need? There will be a moderate elevation of white blood cells with a shift to the left, which indicates more immature white blood cells with appendicitis. Quote, simple appendicitis. So you'll see an elevation 10,000 to 18,000. When the white count gets above 20,000, that may indicate perforation. They're getting sicker. What is our nursing management and treatment plan? We must keep these patients NPO because they most likely will have surgery. Surgery may be done via laparoscopy. That's where they're going through the umbilical area, and it's really quite, they've made such a huge improvements as the day surgery. They probably go home the same day unless they ruptured. There's a newer procedure called NOTES, N-O-T-E-S, and that stands for a natural orifice transluminal endoscopic surgery. And it's exactly what it means, natural orifice. What is the natural orifice down there? Okay, that's where the surgery will be done through. Exploratory lap is done if the diagnosis is not definitive in any other way. So they'll go in, they don't know what they're going to expect, so they're ready for anything once they go in there. It could be a simple, quote, appendicitis, or it could be something much more complicated. Pre-op teaching is limited in these patients due to the emergent nature of the surgery. With chronic, now we're going to talk about chronic inflammatory bowel disease, specifically ulcerative colitis. Ulcerative colitis and Crohn's disease are the two most common IBDs. All right. Ulcerative colitis starts in the rectum. I included a diagram of the bowel here just to help us all refer to where things are. With ulcerative colitis, it starts in the rectum, and it will slowly and methodically advance backwards through the colon all the way back into the cecum in the really severe cases. This is the more common in young people ages 15 to 25, and then in the elderly people 55 to 65. These patients with ulcerative colitis, they will have 10 to 20 liquid bloody stools a day. They may have hemorrhage, and nutritional deficiencies are very likely to occur if it's severe. Surgery is not usually needed to treat ulcerative colitis, but it might be, but it's rare. Compare that to the Crohn's disease patient, and I've included a diagram there that emphasizes in red where that ileum is located, because this disease starts in the ileum rather than in the rectum. And it has more of a patchy involvement throughout all layers and areas of the bowel. It does not have a steady progression like ulcerative colitis does. It's, you know, you can have healthy bowel in between unhealthy bowel areas. The most likely age groups to be affected by this disease are those ages 15 to 40. They will have 5 to 6 soft loose stools a day, and they are non-bloody. This differs from the ulcerative colitis as well. They have, 10 to 20 stools, and they can have bloody aspects to them. The bigger problem for Crohn's disease patients is not the hemorrhagic issue, but the fistula formation. And nutritional deficiencies as well. But the fistula formation is present in Crohn's disease and is just not a problem with ulcerative colitis. These patients, Crohn's disease patients, have a frequent need for surgery, and we'll talk more about that later. Specifically now, we're going to talk about ulcerative colitis and what is it? UC is associated with periodic remissions and exacerbations. They'll get better and then they'll get really bad again. Intestinal infections contribute to the exacerbations. Older adults are at risk for fluid and electrolyte imbalance, which include dehydration and hypokalemia as a result of the diarrhea. So pay attention to that across the lifespan, how the older adult is much more at risk for quick problems with fluid electrolyte issues. The intestinal mucosa in the ulcerative colitis patients becomes hyperemic, edematous, and reddened. This is, they can bleed, as I said, small erosions and ulcers can occur. Those can bleed. The stool will typically contain both mucus and blood. Extraintestinal manifestations, which when I first looked at this word in the book, I thought it was extraterrestrial, and I know that's stupid, but I was tired, okay? So extraintestinal manifestations may occur, and these are migratory polyarthritis, ankylosing spondylitis, and erythema nodosum, which is inflammation of fat cells under the skin. The polyarthritis and spondylitis, those are arthritis type issues. Migratory poly is more joints, and the ankylosing spondylitis is in the spine. So, and then you've got the final one is skin lesions, skin problems. Etiology and prevalence. Well, the etiology is unknown. They may be genetic, immunologic, and environmental influences that cause it to become an issue. With long-term disease, cellular changes can occur that increase the risk for colon cancer in these patients. IBD, both ulcerative colitis and Crohn's, affects about 1.4 million people in the United States, and it's about half and half will have one and the other half will have the other. Sort of, although I've read later that Crohn's affects about 1 million people, so I don't know. It's a lot of people. You won't have to know the number of people, just get an idea. All right, we're going to assess these patients. What do we need to know? Of course, let's dig into history. We always start with the history. And what's the family history? Are there other people in the family that deal with ulcerative colitis? Because it is that genetic little connection there. With this patient, how about the previous and current treatments for illness? What are they taking to help treat this and prevent it from happening already? What are the dates and types of surgeries this patient has had, if any? Let's get a good nutrition history, very thorough nutrition history. What specific foods, I'm jumping down a little bit, but what specific foods might increase symptoms of ulcerative colitis for this particular patient? Milk or milk product intolerance can cause problems of ulcerative colitis. What is the elimination pattern? And be specific about that. The color of the stool, the number of stools per day, what is the consistency and the character of it? Does it have a really bad odor? Abdominal pain, how long has it been going on? How often does it happen? Does anything they do cause it to increase? How about fatigue? Fatigue, why would we need to know about fatigue? Remember, they bleed. I'm sure you know the answer to that now. The relationship of diarrhea to the timing of meals, emotional distress, and activity. Have they had any recent exposure to antibiotic treatment in the past 2 to 3 months? That puts them at risk of C. diff infection. Have they had recent travel, especially outside the United States, and to where? And what is their amount of NSAID use? Though large amount of NSAID ingestion can promote ulcerative colitis. Sorry, I'm stumbling. I am tired. I'll get there. The physical assessment is vital signs. They're usually going to be normal, okay? We're not going to initially see a whole lot of problems there. If they do develop a little bit of a fever, a low-grade fever, and have tachycardia, they may be getting peritonitis, have dehydration, or a bowel perforation. So if you do start getting shifts in vital signs, consider that there may be something going on that needs to be further assessed. It needs to be reported to the physician, so that more testing can be done. The other thing we'll assess is the abdomen for distension, and then we look for those extraterrestrial complications, extraintestinal complications. I did that on purpose. Inflamed joints, mouth lesions. I'm just trying to see if you're awake out there. I'm talking to myself in my house. What do you think? Okay, psychosocial. The inability to control the disease symptoms can be disruptive and stress-producing. Just imagine you're out there doing, you can't even go dancing. My gosh, what happens if you're out there dancing and all of a sudden, whoop, you just, you better know where the bathroom is. These patients will almost always make sure they know where the nearest bathroom is. In a restaurant, they may ask to sit near the bathroom because of the concern of losing it on the way. So it affects their whole life. Just imagine driving a long distance trip. Okay, I can give you a story. I don't know if this guy had ulcerative colitis or if he had Crohn's. I don't know. It wasn't my business to know. But I used to commute when I was a nurse midwife student. I joined a commuting group. My husband was part of it, so that's why I did it. And the guy, the driver, really nice guy, and he would drive us from. I was in Chicago, so he would drive us this hour-long trip from the suburbs into the city. This poor guy, I tell you, at least every time, about 3 times a week, we would have to pull off to a bathroom somewhere. He'd get off the next exit, run into the gas station, and we'd sit in the van, blah, 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 waiting for Glenn. His name was Glenn, I just remember that. Waiting for him to come out of the bathroom. We felt so bad for him, but we're all like looking at our watch, I felt bad for him. I said, I hope he's okay today. I never thought of him until today. But yeah, you have to plan your whole life around your bowels. Can you imagine? You have that tied to the toilet feeling. Okay. Anxiety and depression may result. Now, this particular gentleman, he of course managed to keep a job, and he did fine. He did a good job, but I bet his office was near the bathroom. I don't know. All right, eating may become stressful rather than enjoyable. Not knowing how your body's going to react to what you put in your mouth, okay? How is this affecting their life events? Does it affect their ability to attend cross-country type family things? Anything that's going to potentially cause them to have to leave an event quickly. Going to a concert, can you imagine being in a crowded concert and then you got to find the bathroom quick? Ooh. What stress factors is the patient experiencing that are not even related to IBD? What else is going on in their life? What is their family and support system? Do these people understand, or do they ridicule him or just be frustrated? The van pool was very understanding. We were very supportive. Of course, the patient may have concerns regarding that possible genetic basis and associated risk factors for cancer. And additionally, interestingly, the book brought this out, does the patient have internet access for education information? It's good to have the ability to reach out in the middle of the night if you need to you're so frustrated, you can start maybe getting information or finding out where support groups are. It's just good to have that handy and easily available. What labs need to be checked? Okay, first of all, of course, the CBC. They may have anemia, so we want to check that hemoglobin level, right? Let's look at those WBCs. Let's look at the C-reactive protein and then the SED rate. If those are elevated, that may indicate inflammatory disease is happening. Low electrolytes may happen due to the diarrhea and the malabsorption. Hypoalbuminemia is found in patients with extensive disease. That would be a severe problem, a severe disease causing that problem. Diagnostics that may be done are the magnetic resonance enterography or colonoscopy. That's the kind of the gold standard, remember, for cancer. The colonoscopy can be very useful in those patients with a 10-year history of ulcerative colitis due to their risk of colon cancer. And I know on that slide about colonoscopies, I don't know if I ever answered my own question. I talked about the elderly patient, how we would not want to have them do the go lightly and the massive stool movements to prepare for those. Well, after I finished my recording for you guys, I did look it up, and elderly patients aren't even recommended to have a colonoscopy due to the risk of complications from the procedure. Not the procedure, but the preparation for the procedure. Mainly because colon cancer in the elderly, they take so long to become where they're affecting the patient's quality of life that it's a risk-benefit ratio. So if you do a colonoscopy on an 82-year-old and they have colon cancer, you're not going to do anything anyway. So why even bother finding out, okay? Because they're not going to treat it. The treatment's going to kill the patient before the colon cancer would. So that was the answer I meant to tell you, and I forgot to tell you in class, but that was why we do not even do the colonoscopies on the elderly, let alone all that preparation. We just don't do it. The main goal in treatment is to decrease diarrhea, to develop formed stools, and have an increased control in their bowel movements. That is the gold standard. I'm using that word a lot. That is the big goal for these patients. Non-surgical treatments would involve drug and nutrition therapy. Physical and emotional rest is very important. Teach the patient to record the stool patterns to include the color, volume, frequency, and consistency. They need to monitor their skin in their perianal area for breakdown. Stool is very acidic and will cause skin breakdown. And can you, okay, get the softest toilet paper out there. And actually, I know I say that and you guys might laugh, but it's true. They really need to have really soft tissue paper, and the, I can't remember what agency, but whoever deals with colitis and IBD, the national agency, they have special wipes for patients that deal with this to help preserve that skin breakdown in the perianal area. So it's, yeah. Okay, they must weigh themselves 1 to 2 times a week and watch for decrease in weight, or if they're doing better and gaining a little weight back. They may do stool cultures to check for the C. diff or anything else contributing to the problem. This is a big slide of drug therapy, but I do want you to be familiar with these, okay? We'll take them one by one. I'm going to try to pronounce them all. This should be interesting. Aminosalicylates, those are used to treat mild to moderate ulcerative colitis episodes, and it helps to maintain remission. They're also called 5-ASAs. ASA is aspirin, right? So 5-ASA. They have an anti-inflammatory effect as they do inhibit the prostaglandins. They're usually effective within 2 to 4 weeks. If the next line of potential medication is sulfasalazines. I think I said that right, sulfasalazines. An example of that is the azulfidine. That is metabolized by intestinal bacteria to become the 5-ASA. So it's the same thing. The bacteria in the intestine changes into be basically like an aminosalicylate. The glucocorticoids, example of that is prednisone. These are used during disease exacerbation, and it's used to decrease the inflammation. Remember the side effects of any of the steroids, okay? You want to know these forever. Hyperglycemia, osteoporosis with long-term use, not episodic, but long-term use. The peptic ulcer disease can happen, and they have an increased risk for infections due to the suppression of the inflammation. So it does put them at an increased risk for infection. Another medication line of treatment are called immunomodulators, and examples of these you may have heard them on advertisements. I know I have Remicade and Humira, right? Oh, are you going to make me say those words? Remicade, infliximab, and Humira, which is, oh Lord, adalimumab. Adalimumab. What the world? Adalimumab. Seriously, who named that? Okay, I'm moving on. The immunomodulators modulate the immune response. It alters that, changes it, so it doesn't get, so it has a little better effect. It provides a synergistic effect when used in combination with steroids. So you would never use immunomodulators alone. They are used to help the steroids work better. Okay. Monoclonal antibodies that reduce activity of tumor necrosis factor, abbreviated TNF, and therefore this also decreases inflammation. So that's another way that immunomodulators work, is to reduce activity of the tumor necrosis factor. Ooh, I got through that okay. Antidiarrheals. Examples of those are diphenoxylate, hydrochloride, and atropine sulfate, which is otherwise known as Lomotil, and loperamide, which is also called Imodium. Okay, so the antidiarrheals are used to help, obviously, minimize the diarrhea. But it is imperative to use antidiarrheals cautiously because they can cause colon dilatation, or dilation rather, and toxic megacolon. So those are used very, very sporadically or sparingly in these patients. Off the medication and onto non-medication treatments would be nutrition, therapy, and rest. The severe hospitalized cases are kept NPO to provide bowel rest. We don't want that bowel to be creating more acid and movement and all that. We want it to relax and rest and heal. These patients may be on TPN for nutrition. The less severe patients may be on an elemental formula, which are known as Vivanex Plus or Vivanex TEN. And these are absorbed in the small bowel, and therefore they reduce bowel stimulation. So the place where they're absorbed prevents it from getting lower down where it stimulates and causes a problem. Then there's the personal restrictions. Each of us are different in how we tolerate certain foods that, somebody's lactose intolerant, somebody else can eat ice cream every day, that kind of stuff. So have the patient track which foods tend to cause an increase in symptoms. Typical ones could be caffeine, alcohol, raw vegetables, high fiber foods, of course lactose, carbonated beverages, pepper, nuts, corn, dried fruits, and smoking are all the most common GI stimulants. So we would teach these patients to avoid those particular foods or behavior of smoking if they cause symptoms. Surgical management. I'm going to go into a little bit of detail because I was quite interested in this, so I detailed it out. This one surgery basically, so kind of bear with me on this. The surgical management may be needed to treat complications such as the megacolon, hemorrhage, dysplastic biopsy results, i.e. cancer. Okay. So the patient going into surgery may need to be prepared for the possibility of an ileostomy. Gold standard is called, oh, I knew I was going to have to pronounce this, restorative proctocolectomy. That wasn't hard, proctocolectomy, with ileopouch, anal, and anastomosis. And there's the abbreviation there. So let's talk about the RPC-IPAA. It is performed, believe it or not, via laparoscope. It's amazing what we can do in just a little tiny hole and 2 holes in our belly. It takes 2, not just 1. You got to have 2 holes, but yeah, it's amazing. It is a 2-stage procedure. The first stage includes removal of the colon and most of the rectum. The anus and anal sphincter remain intact, so those are kept in place. A pouch is created using the last 1.5 feet of the small intestine. This pouch is then connected to the anus. Then, while that is healing, to allow that to heal, a temporary ileostomy through the abdominal skin is created to allow healing of that internal pouch. Once that internal pouch has healed, then the second stage of surgery happens, and this would be where the ileostomy itself is closed. These 2 surgeries are anywhere from 1 to 2 months apart. But the really wonderful thing about this surgery is bowel incontinence is usually excellent. No, bowel continence is usually excellent after this procedure, and they may have leakage of stool during their sleep, but antidiarrheal drugs will help this. But again, be careful with the use of those, as we've mentioned. But But anyway, patients that have this procedure are generally very, very happy that they had it. Their quality of life has improved tremendously. The second type of surgery, I'm not going to go into it with as much detail, but that would be a total proctocolectomy with permanent ileostomy. In other words, they remove the colon, rectum, and anus. It's all gone, and then they surgically close the anus, and the patient forevermore will have the bowel elimination done via the ileostomy. Pretty straightforward. Post-ileostomy, initially the stools will be loose, dark green in color, and liquid, very much a liquid that may contain some blood. Remember, it doesn't have all the bowel there to provide absorption of the water and that, so it's pretty watery. Over time, though, what's called ileostomy adaptation occurs. The small intestine will begin to perform some of the functions that had been done by the colon, including absorption of the increased amounts of sodium and water. And this is what causes more of a reduction in stool volume. It becomes less watery, more pasty, and it changes to more of a yellow-green or a yellow-brown. So over time, the small intestine just kind of steps up to the plate and does some of the work of the colon. Odor is minimal in these patients, which is really nice. The malodor is minimal. It might have actually a sweet sort of smell to it. Excuse me. If it does begin to smell foul, that may be a sign of blockage or infection. So patients need to be taught that if it starts to smell bad, go to see your doctor, surgeon. A pouch must be worn at all times with ileostomy patients. The stool contains many enzymes and bile salts, and these are very irritating to the skin. So you don't want the stool to ever be just hanging around on the skin. So they have to wear a pouch, and skin care around the stoma is a priority. Gosh, you don't want to get skin breakdown in addition to all this other stuff they're dealing with. Post-stoma nursing care. What do we need to do as nurses? What is your responsibility going to be? Well, initially the patients are NPO and they may have an NG tube, so you're going to have to, of course, manage the NG tube, which is usually removed in 1 to 2 days, depending on if their bowel sounds are coming back. Food and fluids will be slowly reintroduced. We don't want to overload a bowel that has been empty and that was resting. We have to help these patients adjust and learn the required care, how to take care of this stoma, and we use the wound care nurse. They're excellent at this, but we need to know what the wound care nurse will be teaching them so we can not emphasize, we can support the teaching. The hospital stay is usually from 1 to 4 days, depending on the surgery type. Body image, believe it or not, may actually improve. Now you would think, okay, now they're pooping in their abdomen instead of down there. But do you realize they don't have to watch the clock? They don't have to sit near the bathroom. They can drive all the way from their home to Atlanta or to Chicago or wherever, because things have calmed down and they have control. It's a control thing. Finally, even though it's not ideal, its control is back within their ability, and that can really improve how they feel about their day-to-day activities. Teaching is vital. What we want to teach them is that the internal pouch can become inflamed, so we need to let them know what to watch for that. We need to teach that they may have burning during bowel elimination after that second stage of surgery, because gastric acid cannot be well absorbed by the ileum. So they're going to have more of an acidic type bowel, and that can burn. They need to omit foods that can cause odors or gas, specifically cabbage, asparagus, Brussels sprouts, and beans. And you know, I didn't know until doing this that Brussels sprouts, Brussels was plural. Go figure, I learned something. All right, so those are the gas producers. Omit foods that are not easily digested, such as the nuts and the corn, and then be alert for specific foods that are not well tolerated by them personally. And they should keep a food diary and a reaction diary. That will help pinpoint those items. Pain management. The goal is to decrease pain experienced by the patient. They may be using pharmacologic or non-pharmacologic methods. An increase in pain may indicate development of complications. We need to help the patient identify foods that increase abdominal pain, cramping. Antidiarrheal drugs may help reduce the discomfort, and we need to provide them with gentle but consistent perianal care teaching. What can they use to help prevent skin breakdown and that will not irritate the skin that's constantly being subjected to the stool? Additional concerns for the ulcerative colitis patient: we need to monitor them closely for signs of a GI bleed. And then we go into more of the psychosocial, explore their feelings and concerns regarding sexual issues. I'm sure that's got to be an adjustment. Including the partner in on the discussion may be helpful. It depends on what how the patient wants to approach it, but that cannot be an ignored area. Explore their feelings and concerns regarding the social situations that can cause anxiety. As I said, driving a car for an hour, how are they managing to deal with that? Evaluate them for depression and refer to appropriate mental health resources if necessary. What are the support groups? Those can be very instrumental, even if it's an online support group, and very instrumental in helping them realize it's going to be okay. And then evaluate them for need for home health assistance. Some people may need a little more help with that wound care, the ileostomy care for a while, depending on the dynamics in the home and the patient's abilities. In conclusion, with ulcerative colitis, our outcome goals are that the patient will verbalize decreased pain, gain control over bowel elimination, not experience lower GI bleed, self-manage the ileostomy if they have one, maintain peristomal skin integrity if they have a stoma, and demonstrate behaviors that integrate ostomy care into his or her lifestyle if the ileostomy has been performed. Crohn's disease, what is it? Crohn's is a chronic inflammatory disease of the small intestine most often, or the colon, or both. It most commonly affects the terminal ileum, and remember I showed you the picture of that little terminal ileum down there. It is slowly progressive and very unpredictable. They may have normal sections of bowel in between the affected areas, as I mentioned. It jumps, it skips areas of the bowel. It is also recurrent, just as ulcerative colitis is, with remissions and exacerbations. It's an inflammation that causes a thickened bowel wall. Strictures and deep ulcers occur, which may develop into fistulas. Those are the biggest complication of Crohn's disease. It will result in severe diarrhea and malabsorption of vital nutrients, and anemia is common. What are the complications of Crohn's disease? Very similar as the ones for ulcerative colitis. Excuse me. So in ulcerative colitis, severe malabsorption by the small intestine is more common, so they have more complications of malnourishment and debilitation, whereas the Crohn's disease patient has more common problems with fistulas from the bowel to other organs and body cavities. It can happen anywhere, from bowel to anywhere. Bowel to urethra even, believe it or not. Yes, it's true. In the assessment of these patients, looking at their history, any recent unintentional weight loss, what are the stools, what's the stool story, frequency and consistency, presence of blood, how about fever, abdominal pain, do they have weight loss? Most patients will report diarrhea, abdominal pain, and a low-grade fever. Excuse me, sorry guys. Fever is common with the fistulas or with abscesses and with severe inflammation. Steatorrhea is common, and that is where there's fatty diarrhea. Bloody stool is rare, okay? You have ulcerative colitis, the ulcers cause blood. With Crohn's, you don't have that problem quite so much. It can happen, but it's not the main problem. Abdominal pain is usually in the right lower quadrant and or around the umbilicus. Physical assessment, watch for signs of dehydration and malnutrition. Do that assessment on these patients. Your abdominal assessment would include looking for distension, masses, visible peristalsis. Listen to the bowel sounds. If they're high-pitched or rushing, it may indicate a narrowing of the bowel loops. Are they guarding? Do they guard their abdomen? Are they rigid? Is it tender? Do an evaluation of the perianal area. Look for ulcerations, fissures, and obvious fistulas. Psychosocially, they also will have lifestyle changes that may affect their family, and we need to discuss that with them. How does it affect their family, their activities, their social life? Assess their coping skills and help them identify support systems. Evaluate them for depression and anxiety. Very similar to ulcerative colitis. All the IBDs will be a problem that way. The lab assessment, again, we're going to look for anemia. It's common due to slow bleeding and poor nutrition. Folic acid and vitamin B12 levels may be low. They may have decreased albumin levels due to amino acid malabsorption. And as in ulcerative colitis, the C-reactive protein and ESR may be elevated. You might get white blood cells, they might get white blood cells in the urine, and that's due to infection due to ureteral obstruction or fistula. Fluid and electrolyte losses, specifically potassium and magnesium, can occur. The diagnostics for this would be your x-rays looking for narrowing of the bowel areas, ulcerations, strictures, fistulas. The MRE is done as well to determine bowel activity and motility. Abdominal ultrasound or CT scan will be done. And then they may do a GI bleeding scan if there's evidence of bleeding. The non-surgical treatment for Crohn's is the same as it is for your ulcerative colitis. Medications are same for ulcerative colitis when the disease is mild to moderate. However, if glucocorticoids are used, they may contribute to sepsis as a result of abscess or fistula involvement. So they must be very, very careful if glucocorticoids are used. With moderate to severe Crohn's, is that, oh boy, azathiol, oh my goodness, Imuran, and purinethol. These suppress the immune system and can lead to severe infections. Azathiopurine and mercaptopurine, I don't know. Anyway, they suppress the immune system, and so that can let infections become ugly. Treatment, bowel rest and nutrition, as again, very similar. TPN is being used for severe exacerbation to support their nutritional needs. Again, you're going to see the Vivanex Plus being used. It's absorbed in the jejunum, and therefore it permits the distal small intestine and colon to rest. Ensure or Sustacal may be used in these patients. And they also need to be taught to avoid GI stimulants. Caffeine and alcohol are the two main ones listed in this particular section. Poor nutrition can lead to inadequate fistula and wound healing, loss of lean muscle mass, decrease in the immune responses, and an increase in the morbidity and mortality. Sorry. What time is it? It's like 11:30. I should still be perky. All right, so anyway, we need to really support them. This fistula thing is the biggest thing, guys. All the others important, but man, those fistulas will just take a lot out of these patients. So let's talk about how to manage those fistulas. Systemic infections, skin problems, malnutrition, and impaired fluid electrolyte balance are common complications of fistulas. All right, so it can really mess with these people. The treatment of fistulas is complicated, and it includes nutrition and electrolyte therapy, skin care, and prevention of infection. These patients require at least 3,000 calories daily to promote healing, and high-protein diets are going to be the best healing nutrient. Provide them with enteral supplements, record their I&O, do daily weights, collaborate with the wound care nurse, as we mentioned, And as is true with stomas, the fistula drainage promotes skin breakdown as well, and pouches may be used in these patients until healing has occurred. The location of the fistula may be a problem, though. They are not always easily accessed and treated. They're at high risk for intra-abdominal abscesses and sepsis. You know that leads into potential DIC, right? And antibiotic therapy is commonly prescribed. What type of teaching do we need to do for these patients? It's very similar to the teaching that we do for ulcerative colitis. We need to teach them about the usual course of the disease, symptoms of complications, and when to notify the healthcare provider. Talk to them and teach them about drug therapy, their purpose, the dose, the side effects. And this should be done with any patient that we send home on medications, regardless of their diagnosis. Remind these patients to take rest periods, especially during exacerbations of the disease. Help them identify stress management techniques that will work for them. They may need benefit from counseling. And what physical activity do they normally like to do? That can help relieve stress. Teach them about the increased risk for cancer and the need for frequent colonoscopies. We also need to teach them how to do wound care if a fistula is present. And these patients may need home health visits depending on the location of the fistula and the abilities of the patient or the family member's support system. So that's it on these two exemplars for inflammation of the lower GI tract.